afternoon. I want to welcome all of you to the May webinar sponsored by the Soul Repair Center at Brite Divinity School. Our focus today is on patterns of potential moral injury reported by post 9/11 combat veterans and healthcare workers during COVID-19, with implications for military, VA, and hospital chaplains. So I welcome you to this May webinar. My name is Nancy Ramsay. I'm the director of the Soul Repair Center at Brite Divinity School on the campus of TCU in Fort Worth, Texas. The center provides resources for religious leaders and professional caregivers who support veterans and their families affected by military moral injury. Our mission includes offering free monthly webinars, September through May, focusing on topics as yet inadequately covered or not yet addressed. We're grateful for the support of the Shea Center on Moral Injury at Volunteers of America, which co-sponsors these webinars. That center is led by Dr. Rita Nakashima-Brock, who served as the founding director of the Soul Repair Center. The Soul Repair Center is intentionally interreligious in its focus on identifying effective resources and practices to support healing for those affected by military moral injury. Today's webinar is led by three persons with expertise and experience for exploring important new research regarding patterns of potential moral injury in post 9/11 combat veterans and COVID healthcare workers reported in a recent journal article we've made available on our website. Professor Jason Nieuwsma, dually affiliated with Duke Divinity Department of Psychiatry and Behavioral Sciences, as well as Integrative Mental Health Department of Veterans Affairs, is the lead author of the article. The Reverend Caesar Rentie is Vice President of Pastoral Care at Methodist Health System in Dallas, Texas, and a member of the Soul Repair Center National Advisory Board. Trey Barnett is a retired United States Air Force captain who serves as a VA mental health chaplain in the South Texas Veterans Healthcare System. Kyle Fauntleroy, now Director of Development at Brite, is a former captain in the U.S. Navy and founding member of the National Advisory Board at the center. Kyle will moderate our chat, and Sam McAllister at VOA is our production manager. A link for this webinar will be available at this site in 10 days to 2 weeks. The journal article informing our webinar will remain available at our site. Previous webinars are available at a tab accessible on the Soul Repair Center webpage. Our webinar will proceed with presentations by our panelists and then an opportunity for conversation among them. After the first hour, we'll turn to questions and comments that you share on the chat. These will focus the conversation for the last 25 minutes or so, and we'll close with a brief concluding resource offered by our speakers. I also want to invite you to attend our webinar or our webinars again in September. And we'll look forward to opportunities to continue this educational effort. But now, let's turn our attention to Dr. Nieuwsma and a review of this very important article.
Thank you so much, Nancy. And I'm going to go ahead and share my screen here. If you can give me a verbal to let me know that you can see it.
Yes.
Great. So as you mentioned in your introduction, I'll be talking about an article that we recently had published in the Journal of General Internal Medicine, looking at this comparison, looking at patterns of potential moral injury as we measured them among post 9/11 combat veterans and in healthcare workers during the COVID-19 crisis. I think that most folks who are attending this webinar have some kind of answer to this first question here, moral injury. What is it? I'm putting up here on the screen the two most prominent definitions. Again, I suspect that many folks are familiar with these. The first from Jonathan Shea, a betrayal of what's right by someone who holds legitimate authority in a high stakes situation. The other one from Brett Litz and colleagues, focusing on psychological, biological, spiritual, behavioral, and social impact of perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs and expectations. These two definitions are mirrored in a lot of the research, including the research that I'm going to be talking about today. One focusing a little bit more on this concept of betrayal by others, the other focusing more on transgression by self. You'll see that again in some of our research. Generally speaking, the literature on moral injury, as it's been developed primarily among veterans, this is where moral injury really began as a concept that was being studied empirically at all, has consistently found that moral injury is related to a range of different mental health, behavioral health problems, things like depression, PTSD, substance abuse, suicidality. There are some neurological distinctives even. We were part of a study with others here in Durham where we were looking at veterans with moral injury and those with PTSD and seeing some distinctions even as part of some brain scans that had been conducted. So I don't want to, get into that too much, but there's various strains of evidence that these are distinguishable phenomena, and there are variable etiologic pathways with veterans. Frequently, things like the death of a civilian or killing in combat are noted as prototypical experiences that can lead to moral injury. But when we've surveyed veterans who report moral injury, we'll hear about that kind of thing, as well as a number of other sorts of experiences that I'll show on the slide right after this one. So this comes from some previous research that we've done with post 9/11 veterans and looking at mental illness symptomatology based on their moral injury type of experience. And so what you can see, I know this is a really busy slide here, but we took our sample of post 9/11 veterans in this prior study that we'd done, and we looked at those who reported no moral injury experience, those who had reported witnessing something that they considered to be morally injurious, but denied any kind of agency in that. I know Nancy and Rita, often you'll use the terms kind of receptive and agential moral injury. So these next two categories, omission and commission, would be more of that agential moral injury. So either you failed to prevent something that you thought was morally wrong, so this sort of omission, or you did something that you felt was morally wrong. Whereas witnessing, this category would be maybe a little more similar to the notion of receptive moral injury. And as you can see, as you look across these different domains that we looked at, so we looked at moral injury sequela. This was essentially whether you believe that yourself, others in the world are moral or not, that symptoms of that, or feeling like other people and yourself are not moral and good people, increased depending on what type of moral injury experience individuals had. And then when you look at things like PTSD symptoms, alcohol abuse, depression, suicidality, and drug abuse, you can see pretty similar patterns with some of the highest rates of mental illness symptomatology coming among individuals who had, again, what we might call kind of that agential type of moral injury. However, individuals who reported witnessing, you can see, tended to have higher symptomatology than those who denied any kind of moral injury experience. In prior surveys that we've done of veterans as well, I just want to note this before getting into our study with healthcare workers. We've heard lots of different kinds of things from veterans when we ask them about their moral injury. So absolutely, we hear experiences along the lines of contributing to the death of a civilian, or something like that. But also, we hear about these kinds of experiences, and I won't read all of these. I'll let folks look at some of them, but things like reputation smearing or animal abuse or fraud, waste, and abuse of resources. And, whether all of these things we would say, oh, that's definitely what we would call moral injury or not. The fact is, when we ask veterans about their experiences, these sorts of things come up as well. And so I wanted to put this up here because in a moment, I'll also be sharing some quotes from healthcare workers who participated in a study that we did. So early on in the pandemic, a number of folks began kind of asking this question: what about moral injury in healthcare workers? And I know that Dr. Rita Brock was one of the first ones to ask this question, and they published an editorial about this, and a number of others published different editorials and thought pieces saying, seems like this moral injury thing that has been researched among combat veterans is something that we might see in healthcare workers as well. And so we had opportunity to partner with some colleagues at Duke and at Vanderbilt who were conducting a large study of healthcare workers and asked some questions about potential moral injury that we had previously asked in a study that we had done with post 9/11 veterans, and then to look at those things in relation to different mental health outcomes, as well as in relation to some different demographics and potential high risk experience or context for experiencing moral injury. So our veteran sample was 618 post 9/11 veterans who'd all been deployed to a combat zone. They'd completed our survey, which was part of a much larger study, somewhere between the years of 2015 and 2019. The healthcare workers in this study then, we had a little over 2,000 healthcare workers, all of whom were working during the pandemic and who completed this survey. And this is an important thing to keep in mind. They completed the survey about a year ago, so mid-March of 2021. So you can kind of think about what was going on in the pandemic around that time and how that may have influenced some responses to the survey. So the measures we used for moral injury, we used 2 items from the moral injury event scale, one looking at what we called other-induced potential moral injury, the other looking at what we called self-induced potential moral injury. So for other-induced, the item was, I'm troubled by having witnessed others' immoral acts. For self-induced, it was, I'm troubled by having acted in ways that violated my own morals and values. Again, those terms really map to receptive moral injury for other-induced and agential moral injury for self-induced. What we saw then in terms of prevalence, 46% of the veterans in our sample of post 9/11 veterans endorsed that first item that I read out to you about other-induced or receptive potential moral injury, that they witnessed someone else's immoral acts. Nearly a quarter endorsed having done something and being troubled by something that they did, that they perceived as morally wrong. Among healthcare workers, you can see that the percentages are pretty similar, slightly higher, actually, just over 50% of healthcare workers in our sample reporting other-induced potential moral injury, and then a little under 20% reporting what we called self-induced potential moral injury. That word potential, we're not calling it moral injury, we're calling it potential moral injury for a couple of reasons. One is there's no kind of agreed upon cutoff presently for across this line you have moral injury and on the other side you don't. But we were also just using those couple items that I referenced earlier. And so, based on those 2 items, we wouldn't want to be saying this person has or does not have moral injury. But based on these comparisons, you can see substantial portions of healthcare workers during the pandemic reporting some kind of experience with potential moral injury. And then when we looked at depression, quality of life, and among healthcare workers, burnout, you can see here that those who endorsed either type of potential moral injury, whether we're talking agential or receptive, that they had higher levels of depression, lower scores on a measure of quality of life, and then among healthcare workers, higher scores on a measure of burnout. We also then looked, as I mentioned earlier, at different demographic characteristics, and did this in kind of a controlled regression equation, where we found that among veterans, again, what we called other induced potential moral injury was significantly associated with female gender, non-white race, enlisted status, and post-battle experiences. Among healthcare workers, it was associated with younger age and COVID-19 exposure. And then in terms of self-induced potential moral injury, we found that that was significantly associated in veterans with non-white race and post-battle experiences, and then in healthcare workers with younger age, non-white race, being in a high-risk setting, and COVID-19 exposure. And I think there's a fair amount of kind of additional hypothesizing that we could do around these findings. What we noted in the article was we felt like this was pointing toward individuals who may have less social empowerment being at higher risk for moral injury. And I think that really points us back to, in a number of ways, a lot of the work that Shea, that foundational work that Jonathan Shea did on moral injury, and the importance of power dynamics when we think about moral injury and the development of moral injury. Those power dynamics are significant when it comes to the potential for experiences of betrayal. And again, when we think about that healthcare sample, especially in that sample, we had high rates of individuals reporting that other induced moral injury. On this slide, I'm not going to read all of these out, but just want to give you a sense of some of the kinds of things that we were hearing from healthcare workers that we surveyed in the study. As you look at some of these comments, I think the one other thing that I would note is we also heard from individuals who felt pride in their institution, who felt like their healthcare system had handled the pandemic well. And some of the defining features of that were feeling like there was transparency and sharing of information, and frankly, that there was good leadership. So again, kind of pointing us back to the importance of authority and of leadership, and how that can be very influential in the development or protection against the development of moral injury. So my last slide here, I think there's lots of different things for us to be thinking about, and we could bucket them into two different categories. So one is different individual level approaches for individuals who have moral injury, whether these are employee assistance programs or professional mental health care or staff specific programming. There's different interventions. RISE is one of them. That's just one example that I have here. Learning from moral injury work that others have done. So, we're looking at moral injury work that's been done in VA and things that we can learn from that, as well as moral injury work that's been done elsewhere. Additionally, I think it's important to think about systems level or structural sorts of things that are contributing to moral injury. How leadership, that, like I've already been talking about, can be important. Things like staffing and workload. how can we minimize risk? We know that burnout and exhaustion, one of the things that Shay talked a lot about was sleep and the importance of sleep for protection against moral injury. And can we structure our systems in ways that reduce the potential for exhaustion, and that may also have implications for risk for moral injury. And then finally, I think both among veterans and healthcare workers, people want to feel like they have a sense of mission, morale, and purpose. And I think during the pandemic, a lot of folks may have lost that. So paying attention to how we can reconnect to some of those things is worth doing. With that, I think I will turn it back to Nancy and stop sharing my screen and look forward to hopefully some discussion later on in our time.
Now we have an opportunity. Thank you, Jason. Now we have an opportunity to hear from Trey Barnett.
Thank you, Nancy. And thank you, Jason. Such important work that you have done, and I appreciate it. I've been looking at it and studying it. I'm excited to be here with you, Jason and Caesar, just talk about this issue of moral injury and the healthcare workers. And moral injury for me it's a combination of symptoms and story. Those symptoms, we find commonality in the symptoms of feelings of guilt, shame, self-condemnation, loss of trust, loss of meaning and hope, psychological and spiritual inflexibility, which is all built around this story, the narrative of personal transgression and crossing over lines we didn't think we would do, or a narrative of betrayal of deeply held beliefs. That takes us back to the definition Jason just gave us. But so for me, as a chaplain, listening and hearing the story, bearing witness to the story of someone's pain and their hurt and their trauma, it helps me to hear them and to help them to reframe their story, maybe reconcile with themselves or others, and to really begin to recover from the trauma. Moral injury is that story, that narrative that sometimes we get stuck. They get stuck in the middle of their story. Arthur Frank said, he is the author of this book called Wounded Storyteller. He writes, one of the most difficult duties as human beings is to listen to the voice of those who suffer, which is a difficult task for some. It's a difficult task for all of us to listen to the story of suffering. Sometimes we don't want to be there. We don't want to go there. We'd like to treat the symptoms, give them medication and move on. But sometimes healing and recovery is found in listening to the heartbreak and bearing witness to the heartbreak. The power of a person's story is often overlooked. We rush to treat the symptoms, but as a chaplain, we dwell. That's kind of the ground we dwell in is interpreting and listening and understanding the story. As I think about the last 2 years, working in a hospital, working in a healthcare facility, one of the privileges I get to do is to listen to the story of the patient, our veterans, and I also get to listen to the story of the nurses as they in their break room, or the nurses in their huddles, or as if I leave my door open. I'm here on one of the major hallways. If I leave my door open, maybe a doctor will slip in and after a tough surgery, or if they're going to a difficult surgery, they'll slip in and have words or ask for prayer, just to hear the story. I get to bear witness to their pain, to their hurt, to their struggle. I get to remind them that they're not in this by themselves. Moral injury is it's an event that happens in community, but it's experienced individually. It's how they interpret their story. And sometimes that's an even more difficult task than recovering from a physical or mental or an emotional wound. We can get through those with time. Chaplain Mallard once said, what often makes both moral and spiritual injury so debilitating. So it's its permanence, it's time, and its pervasiveness. It goes to the core of who we are, the core of our being. And that often appears to the warrior, to the military member. And now as I speak about to our healthcare person, it often feels like that wounds are unhealable. But the work we've been doing, the things that I've seen over the last couple of years, I get to tell you that those wounds are healable. I weekly, I speak to Vietnam veterans who are still caught in their story almost 40 years later. The wounds seem unhealable. It is ironic that they're caught in their story because they have tried to avoid it for 40 years, and yet here they are, still caught in their story. I think Jason would agree with me that avoidance doesn't work. And so then what do? We look for acceptance. We look for engaging those stories in order for us to move forward to heal. It is tragedy. Tragedy reminds us, it brings us to cherish our own mortality, as Jonathan Shea would say, to savor it, to embrace it. Anecdotally, as I've walked through these hallways, the question is, do healthcare workers, are they suffering from moral injury? I reached out to our EAP, our Employee Assistance Program, to find out what's going on in that area. They tell me that during the COVID period, the private mental health practitioners that we employ, they were booked for several months. The waiting list was for several months during COVID. It remains that way even now. Before that, the waiting list was not as much. Our healthcare workers, much like our veterans, have a tendency to repress and suppress the awareness of their feelings, which serves them well when they're working in very difficult environments, when they're working very difficult surgeries. If I can suppress my emotion, not really be there, it serves them well. But over the course of time, if we continue to do that, suppressing the emotions can become harmful. It can become result in burnout. It can result in maladaptive coping behaviors, drugs, alcohol, addictions, when we don't learn how to express. And so during this time, my chief recognized that during COVID, my chief, Kerry Haynes, kind of pushed us forward to go forward to working not only with our patients, not only with our veterans, but to be more visible for the staff. And so every morning we try to show up at nursing huddles. We try to show up at IDTs, letting them know that not only are we here available for the patients, but we're also here available for the staff to talk to. The director of the hospital recognized, matter of fact, he posted Jason's article not long ago and sent it out to the entire hospital. But he recognized the stress, and he asked the chaplains to be more proactive, to be more visible, to be more accessible to the staff. So we've been doing that constantly. Our chief has started a program where he's just weekly sending out a word of encouragement where anyone in the hospital can join it and be a part of that. As I anecdotally look at some of the things that have happened since I've been here, and like I said, I opened my door and a nurse comes in and she expresses, "I'm just angry." And I wanted to know what that anger was about. What was the issue? And she was talking about one of her fellow nurses who had passed away. And she was angry at the nurse who passed away because she refused to get the vaccine. She didn't agree with it. That was her choice. But for some reason, she carried this issue of guilt. She carried this issue of shame. As she began to tell her story, she said, she should have known better. And I should have done something even more. And we talked through those issues. It sounded much like the issues I talked about with veterans and how they felt like they should have done something more, could have done something more. It echoed with those issues of guilt and shame and purpose and meaning, and a need to reconcile and forgive. And so for me, it was an issue of moral injury. Her thoughts of what is right and wrong were violated, were transgressed. She couldn't figure out why she lost her friend in such a way. Another nurse stopped me in the hallway, and she talked about how difficult it was to watch people die and struggle for their life every day, even though this is something in her profession that she does over and over. But in this particular situation in COVID, it just was overwhelming. She wiped her tears, she straightened her back, and she went back into the surgery room. And so she had to suppress some things. It is that kind of crisis that I think sometimes we find ourselves in, and we kind of lose purpose. We lose our sense of meaning. Viktor Frankl said, man's search for meaning is the primary motivation for his life. And when we lose our sense of purpose, we begin to question what life is all about. And that's kind of where we are during this crisis. And then Anton Boesen once said, crisis, no matter what the source, emotional, physical, economic, political, is always in some way a spiritual crisis. Crisis always involves the destruction of meaning. And so some asked the question why a chaplain is involved in that. I think that answers the question in some way. Every crisis that we find ourselves in is a spiritual crisis. I was thinking about the issue that happened yesterday and the tragedy that happened not far from San Antonio, where I'm sitting. Those first responders, those mothers, those fathers who will go through some of the issues that we're talking about even now. But let me stay focused. For our healthcare workers, for us here at San Antonio, we've decided to tackle the issues of moral injury through what we call the acceptance forgiveness therapy. We also use parts of the acceptance commitment therapy. For that, we have kind of empowered the veteran for the first 4 weeks. It's a 14-week program. The first 4 weeks, we talk about what moral injury is, how it compares to PTSD. We go through the change process with them. We talk about responsibility and trying to right-size the responsibility and how to deal with some guilt. What's good guilt? What's healthy guilt? What's unhealthy guilt? And then we deal with acceptance, forgiveness, and restoration. And we, after 4 weeks, we just kind of give them education. It's not sharing your story or anything like that. And then we empower them to say, we're going to talk about these issues even more in our 10-week program. And it's up to you if you would want to be a part of that. And because we've gone through the 4 weeks and we've kind of empowered them, we find that they are really receptive to going to the 10-week program, where we dive even deeper into the issues I just talked about, those subjects we just talked about, and we invite them to share their story. Again, I think sharing the story becomes extremely important because it is shared within a community. Moral injury doesn't happen individually, it happens in community. And therefore, I believe that community needs to help restore and repair the individual as they respond to the issues that are going on in their lives. And so let me pause there. I would agree that there are issues with moral injury in healthcare workers. It's even more than moral distress, but I think we are looking at solutions. And I think as I talked to my chief this morning, we're talking about how to build a program for our staff to recover from moral injury after this pandemic, much like the program we have for moral injuries for our veterans. And with that, I'll turn it over to Caesar.
Thank you, Trey. Caesar.
Yes, thank you. And I think Sam's going to share my slides. Well, thank you for inviting me and allowing me to be a part of this discussion about moral injury and moral injury with healthcare workers. When the pandemic first happened, when news of that came out and we began to shelter in place, and as I watched and listened and read through news reports of how it was impacting New York City and how the healthcare system had become overwhelmed, I was concerned because I knew that that wave would eventually hit Texas, and that because the healthcare systems had become overwhelmed there, that they would probably become overwhelmed here, and that the normal ways in which we operated and the way that which we cared for patients would be disrupted and call for us to have to make difficult decisions in providing care and the work that we do with the folks who come to our hospital. And so I was familiar with the definition and the term moral injury because of a lecture that I sat in on with Nancy and learning this from her. And I saw immediately the parallels and the impact that COVID would have on our staff. And I saw that there is a possibility for our staff to be overwhelmed with moral injury. You can go to the next slide. I think the numbers, start to bear themselves out, and we talk about data all the time. And I think what's important to note is that, while the deaths are the indicator of all of the things that have happened, I think when we look at the $24 billion of extra cost and care that had to go into caring for folks, I think then you have to begin to look at the stress that is produced on systems to operate. And I've always said that, when we looked at this pandemic and the tail end of it, and as we continue to journey through it, one of the things that we need to keep in mind is how much this is costing and what it requires for us to be in this, and that in and of itself produces stress. You can go to the next slide. So, as we think about stress, we know that as our hospitals got impacted by COVID, as patients presented themselves to the emergency rooms, as we had to shelter in place and then began to shut the hospital off from family members and the community, and just only take the patients that were critically ill, and really treated other patients out in the parking lot. My concern was that we were operating in a way that we weren't normally used to operating. And I know that we talk about, providing excellent care. We talk about compassionate care here at Methodist. And I know that, as we carry that and take pride in it, I knew that a lot of the way that we were operating would cut against the grain of who we were as a system, but as individuals working in emergency rooms. I've always known this about healthcare workers, that they get into healthcare for a number of reasons, but they get in because they care about people. And then when they see people suffering and can't help in the way that they want to, it produces a lot of stress and moral injury. You can go to the next. So as I started thinking about it, and as I really started to think about our response to COVID, and as I held in the back of my mind the response really to moral injury, I started to reach out in the community or in our healthcare system to with other content experts and disciplines to partner up and to use our skill sets together as a way to be able to provide support for our staff. And so I reached out to wellness, and I reached out to our organizational effectiveness department, which does a lot of education and continuing education, and has lots of platforms that we would be able to use and would allow us to be able to communicate throughout our system. And then our social workers from our MAP2 program, and then our pastoral care and our faith community nursing program, along with the medical staff who worked with our physicians. We formed a collaborative and a group to be able to respond to this crisis. And so out of that response and that need to respond to what I felt like was the moral injury, the thing that was happening to us as a system, and the people that I knew and have worked with for 25 years, I wanted to find a way to respond to them that would be meaningful to them, a way to respond that made sense to them. You can go to the next slide. And so, our mission as we formed this group was to really provide and really speak specifically to the mental and physical and spiritual well-being of our staff, to really be intentional about speaking about that. And so we really, at the very beginning, tried to normalize the fact that this was not a normal situation, that we were all feeling stress, that our reactions may not be the reactions that we would hope for, but that it was a normal response to the stress that we were feeling. And so we really, really worked to try to normalize what it was that we were experiencing under these conditions. You can click again. So our goal was to provide an intermediate response, to be able to be available when sentinel events happened, when there was something that happened, that we had content experts from all of these different areas to be able to touch the lives of our staff. And I always say this, not everyone wants a chaplain, but they may speak to a wellness coach, or they may speak to a social worker. And so we all work together in trying to provide this connection with them. And if they didn't even want to speak to a chaplain or a social worker or a wellness coach, or didn't want to connect in that way, we used our organizational effectiveness to continue to pump out education and information to our staff through the systems that we had. You can click again. And so we wanted to provide education on various mental health conditions. And so we talked about moral injury. We talked about post-traumatic stress. We talked about ambiguous loss was one. To be able to identify that we had lost something, but we didn't know what we lost, was very important. And it was important to educate our staff on that. And because our chaplains touch not only our families, but they also care for our staffs, we familiarized ourselves with this to also educate our staff about this. And then we did programs, writing clubs, we did all kinds of things to be able to identify what it was that we're feeling so that we could talk more about it. You can click the next one. And then, the other thing that our group wanted to do was to be able to connect people to the resources that were available, both within the system and outside the system. And it's amazing that, an organization will provide all types of resources for well-being. There's all kinds of things that are available, but what was surprising is that a lot of people didn't know how to access those things. And a lot of people sat in silence, and there were a lot of folks who for whatever reason didn't want to share because they didn't want their employer to know. And so we had to do a lot of education on trying to find those resources that were available so that our staff could connect with them. An interesting event happened during this time. It was we had a nurse who reached out to our MHS cares team, and she was not looking for resources for herself, but she was looking for resources for her family. And it was producing a lot of stress for her because it was her granddaughter, and her granddaughter was struggling in school, and she recognized that her granddaughter was depressed, but but her mother didn't have the insurance or the resources to get her the help she needed. And so with our group, one of the things that we were able to do was to find some community resources where she lived. And so her granddaughter lived in another state. We were able to find a resource that was low to free counseling and get her granddaughter and her daughter connected with that resource. And so as I thought about moral injury and how it impacted, it was not only impacting what we were doing with our patients and how we were operating here, but it was all of the things that were happening outside the hospital and all the ways in which they impacted our staff. And so we really worked to try to connect people with those resources when they needed it. And as I thought about moral injury and the way that it was manifesting itself in our life, and how it was impacting us, my thought was to normalize it, to talk about it, to say this is a normal response to the stress that we're experiencing because of COVID. And then what is it that we need to do to be well? I always tell people I'm a recovering athlete. I played football at the University of Oklahoma, and then I played some pro ball. And I'm always telling people that when you play in the NFL and when you play at a college like Oklahoma University, you learn to play with injuries. You learn to play hurt, and as an athlete that there will be times that you will get bumps and bruises, and that you learn to play with pain. But you also know as an athlete that that's unsustainable, and that at some point you have to take care of yourself so that you can get back on the field. If you don't have an environment that really speaks to that and then allows for it to be safe, then what you will ultimately have are players who hurt themselves and play until they can't go anymore. But what you want an environment where people can work through their pain, they can work through all of those things, but they are aware and are able to take care of themselves. And there is an environment that encourages that. And our group was really designed to really try to speak to that from a system level as we all came together. We go to the next slide. So we created the MHS Cares Group. And then when we went to sheltering in place, we sent half of our staff home. There were people that were exposed to COVID, and they had to isolate. And as MHS Cares and our group worked together, it was our faith community nurses that came up with this idea of putting together a care kit to be able to send out to our employees to speak to them. And so we put a care kit together with thermometers, face masks, hand sanitizer at this time. And there were all kinds of things that went into that care kit with a note from the MHS care team to really talk about how we would care for our staff. And then we created not only our group, but then we started doing Zoominars, which was to normalize, which was to talk about things that we were experiencing. We did the critical incident stress management briefings, and then connecting people with the community resources, and then the mental health first aid and the grief support that we were experiencing, or the grief support for the grief that we were experiencing. You can go to the next slide. As a result, I mean, MHS Cares, we do a webinar every 2 weeks. We'll have a speaker, and we talk about moral injuries. We talk about these subjects because we want to normalize it with our staff. As the study shows, and as I've experienced on this front line, that the impact to healthcare, if an institution is not mindful of moral injury, then you will end up losing staff members, and hospitals are all working to speak to this issue and figure out ways to be able to address this issue of moral injury. You can go to the next slide. Some of the programs that we provided to really speak to these issues of substance abuse was our HOPE group. Our critical incident stress management, our HOPE group was a way for us to be able to get our staff who were dependent or struggling with substance issues to be able to have a place where they could be safe and be able to connect with. You can go to the next slide. And another more information and ways that we were able to get that information out to our HOPE group. You can go to the next slide. And then our critical incident stress management, to be able to just kind of name these things for our staff, to make this stuff available, to have these types of brochures in our employee health office, to have them on the floors in the workstations and all of those areas. You can go to the next slide. And then we created an ambassador program for our staff members. And so this was really kind of a peer support group within our staff. And so we worked with this structure that we developed to grow it, to do more things, to be able to connect and deepen the ties to our staff. And so for members that are, for team members that are on the floor, that are sensitive to the needs of their colleagues, we reached out and invited them to be a part of the MHS Cares. And so people from housekeeping and pharmacy and on the nurses units all found ways to connect with one another by using this peer support group in our ambassador program. You can go to the next slide. As we did this, we started gathering information, and we wanted to see how we were doing. One of the things that we did was we developed a tea cart we call it Tea for the Soul, and we started taking these tea carts out with the wellness coaches in the pastoral care department, and organizational effectiveness, and our social workers and faith community nurses, to just really connect with our staff on the floors along with our ambassadors. And as we started going out and connecting with people, we wanted to do a survey to see what we were doing and what was of importance to people. And one of the things that I found interesting in the survey that we did was that the feeling that I'm cared for was an important part of addressing this issue for our staff. And the interesting thing is that there wasn't a lot of money spent on this. The interesting thing is that the effort was put forward and that people felt that they were cared for. You can go to the next slide. And then, we asked, the TCART, what does it do? And it provides support, during a busy work day. You can go to the next slide. And then would you like to see it continue? And overwhelmingly, 100% of, or 99.9% of the employees wanted to see it continued, which continues to tell me that we need to continue to do this work on moral injury. You can go to the next slide. That's the end of my slides. So, as I thought about this article, and as I thought about the way in which we function, I think one of the things that's important for us to note and to know is that moral injury is an issue in healthcare, and that we have to find ways to address it. As I thought about the response and the way in which we were responding to our staff, it began with the notion of understanding and knowing that this pandemic was calling us to operate in a way that went against everything that we had practiced. I mean, we'd never kept families out of the hospital. Nurses now were sitting in those areas not only when the patient died, but then they were the ones that were sitting with family members on doing FaceTime to let them know and to bear witness to that grief. Our staff, they were the ones that were holding the door closed when people were needing help to assess whether certain folks could come in or whether their condition was serious enough, because the resources were so low at the time and there was little that we knew about COVID. And as we look at moral injury, and as we look at how that impacts us, healthcare systems have to begin to think about not only the impact then, but then the aftermath afterwards. What happens afterwards? As I reflect and think about this article, and as I thought about my own experience as a chaplain, probably one of the biggest events was when George Floyd was murdered. That probably had the biggest impact in terms of moral injury to our staff. There was a huge outcry from a lot of the medical doctors, African-American medical doctors, a lot of the nurses had a huge outcry and wanted our institution, wanted the hospital to speak, and to be definitive about where it stood on the issue of race and George Floyd's death, and what Methodist health system was going to be committed to. And as I reflect and think about that, I think about how there's this impact to us when it cuts across the grain of who we are as individuals, but there's also an impact when our institutions don't behave in a way that we want them to. And it was really important for me as a leader in our hospital to be able to speak to our senior leadership and to be able to address this in a way that was prophetic and spoke to the issues that were happening out on the street, but also the issues that were happening inside our hospital and with healthcare. I think that as we move forward as and as healthcare workers, I think it's important for spiritual care to play a significant role in this work of moral injury. I've always known intuitively the connections that chaplains have with staff and with patients and with the community. But what I've come to understand is that that ability to be able to speak to the spiritual conditions of what we face when it disrupts our moral being, we need to have a way to be able to speak that makes sense for how we feel, to be able to speak not only about what was wrong, but we also need to be able to have that language of grace. We need to be able to lament, and we need to be able to ask God if God really cares, or does the institution care? We need to be able to have safe places to do that. And as I saw the work that we were doing as chaplains, the work that we were doing in this MHS Cares group, the work that we were doing to address not only the stress that our staff was feeling across the board, I saw it as an opportunity to really allow ourselves to speak to the spiritual stress and distress that we were feeling. Several days ago, with the shooting here in Texas at an elementary school, once again, it impacted our staff. And this is something far away from where we were, but it impacted our staff, and it required for us, and it continues to require for us to really respond to it. To respond in a way of using that spiritual language to take care of people. So as I close and think about the work that we're doing, and think about this article and the impact that it can have on institutions and leaders who make decisions about budgets and all of those things, I think that there has to be the continued drumbeat of saying, if we're going to be healthy, if we're going to be whole, if we're going to be all that we are created to be and offer the care that we need to, then we need to be able to speak to these issues in a way that makes sense to us, and address them in a way that not only makes sense to the institutions, but to the individuals who work those floors and do the care on a daily basis. Nancy?
Thank you, Caesar. Let's, the four of us, come back together for some shared conversation. I really appreciate what each of you has contributed, and we have some questions from the audience, so to speak. And also, I want to begin with a few minutes for you all to pose questions to each other, because there were certainly points of contact between your presentations. So I'm imagining that your imagination has been piqued by each other's presentation. So let me just open the floor among you for some conversation before we turn to the questions from others. Don't be shy. Jason, you might want to unmute yourselves though. Great.
I'll just say real quick, I really appreciated everything that Trey and Caesar had to say. And I was taking physical notes and mental notes on lessons learned from that stuff, as well as what was in the chat. So just appreciate the thoughtfulness. I'm curious. So you both spoke to a lot of different things at your facilities. In speaking with leadership, Caesar, you were just sort of talking about that. And Trey, I invite any thoughts you have on this as well. But were there areas where you found that there was more receptivity, and were there any areas that you found resistance around? Okay, not that idea. Let's not do that. Anyway, just curious about experiences that way.
Well, here at South Texas, I think we have built such a great rapport among leadership that when ideas were presented, they were received well. How we could engage our personnel here, our director supported the chaplain's ideas, encouraged that. sent out information that chaplains would be available. And we found some collaboration with the EAP program here. And so not much resistance here, but I think that was built up over time with good leadership, great leadership. Current chaplain chief and previous chiefs who built that goodwill in historically and placed it. So not much resistance here. You can find some among not the top leadership, but as you go down into some of the units, those kind of things, they want to know, well, what are you here to do? We're just here to support. We're just here to listen. We're just here to encourage and really help you to lean on your own spiritual strength, whatever that is, whatever that hope is. So.
For me, it was more curiosity. I don't know that it was resistance. It was, what is this? And so I had to spend some time educating people about moral injury. And one of the things that I did was invite Dr. Ramsay to come and do a presentation on one of our MHS Cares Zooms to talk about moral injury. And then as when she came and she presented, this was all part of really educating that senior leadership and helping them understand what this was. This is why I appreciate articles like this, and it helps connect the dots, and the data really proves itself out. Because at the end of the day, administrators, you know, the resource is the work staff, and it's like, how do you take care of the work staff and how do you connect with them? And so the very first thing was to be able to identify and say, post-traumatic stress, moral injury. This is something, and this is here, and this is the reason why. And so once I was able to connect the dots in that way, and to be able to show our senior leadership that this was an issue, and this is the reason why I appreciate studies like this, because I could share the study with our leadership, and then as this information, you know, kind of goes through, you know, advisory boards and all you know, all of the folks that speak to administrators, it really helped be able to bridge the gap and say, these are the resources we need in place. One of the things that our foundation did was gave us $147,000 to just towards this effort, because we really worked hard on just educating people about this is what's going on, and this is how we need to address it. And now it's really starting to pay itself off, because when we start looking at employee satisfaction and our response to our staff, we are above the rest of the systems in our market because we responded in this way.
Yeah, let me just follow up and say leadership makes a difference.
Mm-hmm.
As I said in my presentation, our director sent your article out almost the day I got it to, when Nancy sent it to me. He sent it out to the entire South Texas, and I forget how many thousands of people we have here, but he sent it out to everyone. So he was on top of it even before many of us. So.
I want to jump in for a moment with an observation, given that it's 10 after. Several of you, especially Caesar and Trey, mentioned what spiritually we call lament.
Mm-hmm.
It is a person voicing deep pain, and the ways in which, whether in your office as a primary caregiver, Trey, or in programmatic and communal ways, as you were describing, Caesar, you described Trey, and you even referenced boys, and that's a first. I'll not go into that, but I was thrilled about that. That what we know from both Hebrew and Christian texts is that in that lamentation, the deepest kind of anguish, comes from someone who feels their suffering is not recognized, that they need to have their identity, their value acknowledged. And that I thought what you were describing is really important to that. Last spring, about this time, I think it was the April webinar, we did on lamentation with a distinguished Hebrew Bible scholar and a Navy chaplain, talking about how important that is. And one of the things that strikes me is the contrast, at least in the military, that many chaplains have told me that people hold back from seeking mental health care because it goes on their records. So one of the contrasts related to responding to these indications of military moral injury, whether receptive or agential, is it's contraindicated to let people know you're feeling that pain, and to seek professional care for it. So that might be one of the lessons, one of the contrasts here in what you all were raising. I wonder if there's any response to that.
Yeah, I mean, I think that I think the lessons that we need to draw from this is that we need to say that it's okay to ask for help, and in some ways figure out a way to incentivize that, that it is okay. I think when institutions are able to put in place systems that encourage people to come forward and to say that it's okay that they need help, then it provides an opportunity for them to talk about what's wrong, and how we can get it right. And so the power of lament, and we had those showed, I mean, a lot of, and it's curious. I mean, it's different ways in which they showed up.
Sure.
So for me, as I took the opportunity as a leader in this organization, because I do a daily devotional, I used one of those devotionals as a lament. I lamented about what I hated about all of this, and God, do you care? And it opened up an opportunity for others to be able to speak, and for this place to be safe for the workers, that it's okay to speak in this way directly to the institution they need to hear and we want to hear. And so encouraging that is important, and it's an important part of healing.
Absolutely.
Not only just for the workers, and not only for I'm just saying workers, but nurses that are and staff members that are on the floors. But it's important also for the administration itself, and for the institution, because we all needed it.
One of the other things, thank you, Caesar. One of the other points that your paper raised, Jason, which I think Caesar and Trey both from his previous career in the Air Force and now as a mental health provider, your research pointed out the correlation between moral injury and a sense of power in their organization. So it was very helpful to see this, the fact that your research included a number of enlisted persons with some correlation to minoritized racially. And then in the healthcare workers, also persons who were not in the administration or nurses or doctors, but maybe orderlies and such. And I think I'd be helped for us to explore, for you all to reflect on what this means, because I'm particularly interested in military moral injury, but the correlations there with how moral injury might correlate with folks that feel sidelined, or it's dangerous, or they're disempowered in either the military or the organization.
Yeah, no, so I'm a clinical psychologist, right? And some of the things that you're pointing toward, Nancy, with that question are reasons why I feel privileged and feel that it's extremely important to do this kind of work with folks like yourself, Nancy and Rita, who are theologians, and Caesar and Trey, and doing the chaplaincy work, because we tend to have a lens in mental health that locates a problem within an individual, and how can we care for that individual? And that's an important question, but is also a lens that has some blinders on it, right? We can ask that question with something like, and I probably shouldn't go listing diagnoses here, I'll get in trouble, but obsessive compulsive disorder or something, OCD, it doesn't really beg the question in the same way of like, how have we structured society in a way that's contributing to OCD? Like we can probably think a little bit more about how can we provide care to this individual that's, struggling with some of these symptoms, and we can have evidence-based psychotherapies. Moral injury, I mean, Caesar, you were talking about, right, this confluence of the pandemic and then George Floyd's murder, and then like, okay, how inappropriate would it be to say, people who are distressed in the aftermath of George Floyd's murder, we're going to provide individual care for you to work through that distress. Well, okay, like there's probably a place for that, but if we stopped there, hello,
Yeah.
This is begging bigger questions about how we've structured things, and we can beg those questions when we look at military conflicts. We can beg those questions when we look at healthcare systems. We can beg those questions when we look at racial dynamics. I think moral injury like begs these questions, and to even tie it back to your previous question there, Nancy, around lament. I know you've done work in that area, and I think it's just such a powerful and prophetic thing that chaplains can bring to the table. Again, yes, in terms of individually, people who want to lament, but also communally, right? Moral injury is one of these things that it's like, whether it's a agential type or a receptive type, either one. Agential, I'm a bad person, and I shouldn't be around other people, and I need to isolate. Like I need to move away from community. Or receptive, other people can't be trusted, and so I need to isolate. Either way, you're moving toward isolation and doing a thing by yourself. But the notion of like lament and doing that in community, and okay, like we're naming this together. And I'm not sure that's appropriate for everything, but I've certainly seen powerful examples of that being done well by chaplains and healthcare systems during COVID, and in the aftermath of George Floyd's murder. And so I just think there's so much that this partnership, from a psychologist's perspective, this partnership can really bring to the table to holistically trying to address moral injury.
Yeah, and I think the thinking about the lament, it was the individuals. It was actually, surgeons and doctors, African American surgeons and doctors, that wrote letters, that told stories about lynchings that happened in their families. And they were lamenting this, and they wanted to know what the hospital, I say hospital, but administration and senior leadership was going to say about this. And, as a Black man, I know, and I know the experience of racism. I mean, I live it every day. And so, I'm standing on the same side saying, do you care that we perish? And how do we, how do we say that? And I think it's the ability to be able to say that then invites this place of healing and literally moves the institution. It has moved our institution and psychologically in the way that we now are beginning to address healthcare, to look at the social determinants of health, to look at the two disparate zip codes in our area, and to say we cannot have this happen again, and call ourselves a healthcare system. That moral injury was institutional. It happened to all of us. And it was and I think it was having the language to be able to address this with the CEO and chief operating officer and HR director. Having the language to be able to do this was helpful, and moving a system.
Yeah, I appreciate that. For me, as we were talking about lamenting, we do have a section in the program that we do here for writing laments, and we take them through a process of what a lament is and how it's structured in sacred writings, sacred texts, and scripture. And it come to the end of that, it is about expressing it and getting it out and letting it go, because there are some questions in life that don't have answers. And it is being able to hold that ambiguity and still move toward the things that you value. I don't have the answer for why there's racism. I don't have that answer. I don't have the answer to why I have to tell my children certain things before they get in the car and drive away. I don't have that answer, but I want you to still move toward the values and the things that you have before you. And so it is that, as I would use Jason's words, to being able to hold and move, in the words of acceptance commitment therapy, to be able to hold the pain, hold the trauma, recognize it in our moral injury. We recognize it. It hurts. It's difficult. We've had difficult experiences, yes. And yet I can't stay here. I don't know what the next chapter will be in my life if I keep reading the same chapter. And so it is that ability to understand it, to hold it, to understand that life is not fair. There won't be, everything is not, pie in the sky, but we learn how to move forward. I think Amy asked the question in the chat is, can we help people too much that we prevent them from moving forward? I think is something to that effect. I don't know that we can, here's her question. Do we risk helping people adapt and adjust to wrong circumstances that we deflate their effort to make need for social change? I think we can do both at the same time. We need to make social change, but at the same time, we need to help people become unstuck from where they are. Right. In order for them to move forward.
I think that part of the point that you were making when you talked about lament earlier, Trey, when you raised the topic, that matches up with what folks like Levinas and Arthur Frank lift up, is the importance of you as the care provider acknowledging the pain of the other. That is, that then I know if I'm heard, I'm seen. And Caesar was describing a whole organization that created multiple ways for every care provider, from doctor to orderly, to know that their difficulty was acknowledged and that they were valued. And one of the things, so that to my mind, that's what's really critical about, not only for healthcare workers, but I want to bring us back to the data about veterans and current military that Jason was lifting up, in terms of people, if I can't see somebody get help without it impeding my progress in the military, that doesn't help me feel like my pain is acknowledged, that I'm valued in this organization. And part of what I also value, Jason, in what your data is the attention to what we might call class, to both the convergence of enlisted personnel and also persons who are racially minoritized and women of all of those categories, who what we see in terms of statistics is that, military sexual trauma, for example, apparently went up about 50% between 2017 and 2019. So the suicide rate is also going up because this is unacknowledged. It's related then to the point we were making about where power lies in an organization and responding to pain. We've got about 5 more minutes. There may be more about to say about that, or there may be other things you want to use this time for.
Well, when you were talking about that, and I was just thinking, when you talk about this language and lament and dealing with this trauma, this moral injury, there's the lament, but then there's also the grace, the forgiveness. And I don't think you get there. I don't think you get to that other part of transformation and getting these systems to move until you really deal with this lament, but also are trusted enough to say, let's work together in creating some good outcomes, because in the end, it's the resource, the people, it's the resource that we have that's the most valuable commodity that we have, that we preserve in the end. And without that, we're not an organization. And I think it's important to have the language to be able to identify the moral injury, to be able to identify it, but then to have the language to be able to, to be able to offer the intervention, which is, to me, the lament. It is that thing to really address what it is that we've experienced, and then to have the further language to say, now this is the place of transformation and healing. So having gone through this, I'm better now because I'm at this place of, if I could use this word, grace or forgiveness, that the organization is at that place. That's where this organization is, because it's now starting to think about social determinants of health and how to impact that in the community.
I would say,
Go ahead, Trey.
No, I would just say, add on to what Caesar was saying. It is the issue of power. You mentioned the enlisted, officer, and minority. I fulfill all three of those. For 15 years, I was an enlisted guy. I went to officer school, and for 10 and a half years, I was an officer. And then for all of my life, I've been, African-American. But, and so seeing that, as an enlisted person, we have so much power. That's not so much we can do. We follow orders. We can sustain some moral injury because there are some orders that we follow that are difficult. May not align with our internal values, but we've got an order that we've got to follow. As an officer with troops and sending them overseas with the possibility of their death, that responsibility, holding on to that. I've lost some people that were sent, but going through this kind of right sizing my responsibility, how much role did I have in that? And we can't live in a world where there is no suffering. Suffering happens. We lose people. Bad things happen to good people. And so trying to understand all of those dynamics and the issues of power and understanding where we sit in that sometimes is more than a intellectual exercise. You really got to process it for yourself.
Right. Right.
And positive.
Well, one of the things we have to process is that we're now at 3:30 or 2:30, depending on time zone. But I want to thank you three for really a remarkable webinar and for the contributions that you made, so substantive. Thank you so much. And thanks all of you who joined us for this conversation. Best wishes, gentlemen. Thank you so much.
Thank you.